Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We'll also examine proactive approaches to cancer prevention, and most importantly, how we are breaking barriers to beat cancer in our community and beyond. Today, we are talking about breast cancer screening and also the very exciting launch of our mobile mammography clinic. And today we have Dr. Diana Miglioretti, who is a breast cancer researcher and also lead on Mobile Mammo Plus, and Laura Fejerman, who heads up our Office of Community Outreach and Engagement, among many other duties. And she does a lot of research as well. And ladies, we're both so glad to have you here today. Let's first, before we get into Mobile Mammo Plus, talk about breast screening. And, you think in this day and age, mammography is something everyone has sort of taken on as a routine screening. But what I'm learning is that a lot of women are not up to date on their screenings. How important is this to stay on a regular routine with your mammography? And what age should it start?
So regular screening with mammography is our primary method for reducing morbidity and mortality from breast cancer. The U.S. Preventive Services Task Force recommends biannual screening. That means screening every other year for women from ages of 40 to 74. So women should start screening at age 40 and continue screening regularly until they reach age 74 or till their doctor tells them that they can discontinue screening.
And Dr. Fejerman, what about, and this is one of the reasons why we're bringing Mobile Mammo Plus on board, but reaching those marginalized populations, those particularly Spanish-speaking women or women in rural areas. Why is it so important that we dedicate time and investment in this area?
Because mammography is used mostly by the less diverse, richer women who have regular access to care and get reminders. They don't worry about having to pay for their mammography. But when we look at rates of screening among the underserved, the underinsured, the uninsured, the more diverse individuals with lower education, then the rates go down. And there's a lot of research on barriers to screening, including transportation, childcare, fear of being persecuted because they disclose that they don't have insurance. There's multiple barriers where programs that are geared towards these populations are very important. So we can first remove those barriers or those fears and then help them access screening at no cost or reduced cost.
So I want to make sure it's really clear that under the Affordable Care Act, screening mammography is free for everybody with insurance. So if you have insurance, there's no out-of-pocket cost for screening mammography. Though we do have to worry about women who don't have insurance. And that's one of the purposes of the mobile mammography ban, is to be able to provide this important service to those who don't have insurance.
And to build on that comment, there is a federal program that covers mammography for the uninsured. It's, here in California, it's the Every Woman Counts program. And to qualify for it, there are certain salary requirements. So most people should be able to get a mammography for free, or through insurance or through Every Woman Counts. There's a part of the population that doesn't fit the requirements of Every Woman Count, and they don't have insurance. So that those few individuals, there needs to be additional ways and programs to support them.
With the Mobile Mammo Plus visiting communities within Northern California, how is this going to work within the community? Do people just show up? Do they need to make appointments for this? And then kind of how popular do you anticipate this being?
Sure, I can start. So we're partnering with federally qualified health clinics to offer mobile mammography to their patients. So women will have to schedule in advance, and the clinics will help us do that.
The idea is first to work with clinics where a partnership is already built in place, and we have a clear way of generating appointments, and people know when to show up because this is done through the clinic. However, the hope or the goal is to eventually be able to take the band to health fairs or churches, places in the community where we are going to have our program more actively. We'll have to register individuals maybe in advance, working with the church or the health fair organizers, or doing outreach in the community, and then setting appointments for those individuals. I imagine that also the idea would be that we share a phone number or some way of contacting us for individuals who are interested in mobile mammography, and then we can inform them when the van is going to be nearby and what's the approach to getting screened via the program. But I think the first step is going to be, just so everyone gets used to this model, is working with clinics in advance to set up the appointments.
I think one challenge there is to get a screening mammogram, you need to have a primary care physician who gets the result and then can help with if diagnostic imaging or biopsy is necessary. So by working with the clinics as a first step, they'll have a provider for whom we can put down as who to contact with the report. And so a challenge that we're working through is if we go to a community fair and there is no provider, we need to identify a provider for these women to get the screening mammography report.
I think part of our fundraising is to create a source for bringing patients to UC Davis if it's necessary, or other places where if funds are required, we can support them for the follow-up. Diana, correct me if I'm wrong.
That's correct. So we really would like to see these patients through the whole process. So most women will just have a normal screening mammogram and everything will be fine, but some women are going to require either additional imaging and possibly a biopsy. And so we want to ensure that those women get that care in a timely manner. Our research has found that Black women and Hispanic women have delays in getting that follow-up care. And so we want to overcome those challenges and also make sure they get excellent care at UC Davis. So that's part of the fundraising. The screening mammography is covered by insurance or these other sources, but diagnostic mammography does have out-of-pocket costs typically, and biopsy. So we're looking into ways to bring those patients to UC Davis. And then if some women are diagnosed with breast cancer, where are they going to be treated for their breast cancer? And we'd love to bring them to UC Davis for their care.
So how long will it take to get a mammogram on the Mobile Mammo Plus bus? Is this a pretty easy process for women to go through?
From our experience with the pilot mobile mammography, it's usually a 15 to 20 minute process. So we can schedule quite a few mammograms a day because of the how quickly you really do this. I think what takes most of the time is like registration, person getting ready, getting changed. The actual mammography imaging is literally 5 minutes or 5 to 10 minutes.
That's good to know. We know that Latinas don't get breast cancer as much as white women. However, when diagnosed with breast cancer, they are more likely to die from it. And it's, a high rate of breast cancer among Black women as well. We're now hearing that younger women are also statistically showing up with higher rates of breast cancer. Why do you think this is happening, where we're seeing it in the younger generation?
I can say, so the U.S. Preventive Services Task Force recently lowered their age to start screening to 40. It used to be starting at 50. But because we're seeing a rise in the incidence of breast cancer in the 40s, they now recommend screening mammography from the age of 40. We don't know why the rates are increasing. I will say that older women are still at higher risk of breast cancer. So even though incidence has gone up in the 40s, it's still quite low. And breast cancer incidence greatly increases with age. So it's really the women in their 60s who benefit most from screening mammography, but though there is a benefit for women in their 40s and 50s.
Well, Dr. Miglioretti, as you've done a lot of research around screenings, you've also landed on preferring, if I'm correct in saying that, personalized screening schedules. What exactly does that mean, or how does that apply to women?
So we're developing methods so we're developing screening strategies that are more personalized based on women's risk factors, and not just risk of cancer, but risk of having an advanced cancer despite regular screening. And so, for example, we found that Black women are at about similar cancer incidence as white women, but they're much more likely to be diagnosed with advanced breast cancer, even if they're regularly screened. And so these women may want to undergo more frequent screening every year instead of every other year. And we're trying to identify groups of women who might benefit from supplemental imaging in addition to annual mammography. So we know women with dense breasts are more likely to be diagnosed with advanced cancer under biannual screening, and obese women, postmenopausal obese women, are more likely to be diagnosed with advanced cancer. And so we're trying to move towards a strategy where these women might undergo annual instead of biannual screening, or even receive supplemental imaging such as supplemental ultrasound or MRI. Because our main goal of screening mammography is to diagnose breast cancer at an early stage when it's more treatable. And so we really want to identify those women at high risk of an advanced diagnosis and make sure that they're screened more intensely so that we can increase our chances of diagnosing the cancer at an early stage.
And there's also a lot of work being done in the genetics realm to be able to use, for example, polygenic risk scores. There's a lot of publication combining traditional risk factors, density, and polygenic risk score, with the goal actually of being able to better predict who's gonna get, who's more likely to get breast cancer and who's more likely to get aggressive cancer. And so there's really the technology approach to trying to solve this. So we don't overscreen people and we don't underscreen people.
One exciting area of research that we're doing is looking at AI. And so I'm very excited about the possibility of AI for flagging women who are more likely to be both diagnosed with breast cancer in the future, but also have a breast cancer missed on mammography. So we're evaluating AI from 4 different vendors that have been FDA approved to see if it can both improve detection of breast cancer at a screen. So if a woman comes in for a screening mammogram and the radiologist doesn't see anything, can the AI flag a cancer that's there and detect something that's maybe missed by the radiologist? And then we're also evaluating that AI can identify women who are at high risk of cancer in the future. So I mentioned previously breast density. Women with high breast density are at increased risk of cancer in the future. But we use a very crude scale, a BI-RADS scale of a 4-point BI-RADS scale of almost entirely fatty up to extremely dense. So I'm sure the AI can see something way more complex than that in terms of texture of the breast density that's probably related to future risk. And so we're hopeful that AI can identify women at high risk of a future cancer or future advanced cancer, and those women might want to get more frequent screening.
And Dr. Miglioretti, I understand you will be doing research on the mobile Mammo Plus bus in addition to screening women. Can you tell us about that?
Yeah, so I co-lead the Breast Cancer Surveillance Consortium, which is a consortium of breast imaging registries throughout the United States. But those registries tend to collect data from academic medical centers, and it's also community facilities, but that it tend to be places where wealthier women get their care. So we have a real gap in understanding how mammography performs in marginalized communities that are getting their care at federally qualified health systems. So this is a really exciting opportunity to be able to collect data from these women and see how well mammography works for them, whether these women might benefit from more frequent screening or supplemental imaging, and just different needs of these communities.
In addition to that aspect, I think the future we see is also incorporating genetic testing and AI into the mobile Mammo Plus setting to then and then we need to do research on this, but can can we, for example, do the first mammography for someone, get a blood sample or saliva sample, estimate their genetic risk, looking at polygenic risk score and high penetrance variants, use AI to look at their mammographies, and then combine all that to give this person a recommendation. Well, maybe you don't need to do this again for 3 years. But we need to test the feasibility of doing this. And so I think that would be one dream research project.
Yeah, one of my dreams, and this could be a big goal, is to see if we can use AI to flag women who need immediate interpretation of their screening mammogram. One challenge that we expect is we have women there for their screening mammogram, but if it's a positive mammogram, if they see something abnormal, they're going to need to get worked up with diagnostic imaging. And we're very concerned that the loss to follow-up rate is going to be high, that it's going to be hard to get these women to come back for diagnostic imaging. So what we hope is that we can use AI to flag mammograms where there's a high probability of having an abnormal finding and do the diagnostic imaging on the van while the woman's there. That's going to require a lot of coordination where we're going to need to get those mammograms virtually read off-site. But that's one of our dreams.
With the research happening with the AI right now, how far away do you think that is to becoming a reality or a usable technique?
AI is being used in some clinical practices already with minimal evidence. So FDA approves AI just using reader studies. So basically, you get some readers in a room, you read a mammogram with and without AI, and you show that it's doing at least as well as, with AI as without AI. So I think our research is extremely important to validate those AI algorithms in different samples and more diverse samples. A lot of these algorithms were developed in white women, European women. And so this research, I think, is very important to see, does AI work as well in Black women or Latina women? But it is being used in practice right now. Some facilities are charging women out of pocket if they want AI. So they're saying, oh, we've got this new AI. If you want it, insurance doesn't cover it. But if you pay $40, we can use the AI. So it's really critical that we conduct these studies and validate these algorithms to see if they are helping women.
Dr. Miglioretti, you also recently conducted a very large-scale study on the impact that false positive results are having on women coming in for, future screenings. Can you tell us where AI might have a role in this in terms of getting results faster, that maybe same day? I think you recommended as part of your findings.
So we conducted a study where we evaluated the probability of returning for a future screen within 30 months by the mammography result. We found that women with a true negative mammogram, so then everything was normal, they didn't have cancer, were most likely to come back. But if a woman experienced a false positive result, mostly either they were told come back in 6 months, let's see if there's been any changes, or you need a biopsy and that biopsy turned out to be benign, they were least likely to come back for another screening mammogram. So we can imagine some reasons for this might be the anxiety associated with that, or having to come back every 6 months for a while to see if there's changes and it turns out to be normal, when they might think, oh, this is a waste of time. And maybe that either anxiety or the feeling it's not worth it prevents them from coming back for another screening mammogram. So it's really important for us to find ways to reduce anxiety and stress associated with false positive mammograms. One idea is if we could use AI to flag screening mammograms that are likely to be abnormal, the radiologist could interpret that screen while the woman waits and then do any diagnostic imaging while she's there. So that would reduce the anxiety of having to wait a couple weeks to get a final result and might improve chances of coming back in the future for future screenings. So it's really important that women understand screening mammography works when it's done regularly. Women should get screened every 1 to 2 years from age 40 to 74. And you need to come back regularly for each of those screens so that we can capture cancer while it's small.
I did want to ask Dr. Fejerman about her Promotories program and the health educators she's using to reach out to the Spanish language Latinas and educate them about the importance of mammography.
Yeah, the program is called Tu Historia Cuenta. We have been doing it for more than 4 years now, reaching out to Spanish-speaking Latinas who are the ones who have the least access to information because of language barriers, and have educated about 1,000 Latinas in California, identify about 10% of them with family history of hereditary breast ovarian cancer, and then navigated them to genetic testing, learning that barriers are at every step of the way. Even once we were able to provide someone with their risk and telling them we recommend testing, then we offer testing for free, we still were not able to test all the participants who were high risk. So I think this happens in the realm of genetic risk and family history, as well as just regular mammography. It's anxiety and fear is one barrier that I think we still have to work on. And I don't think it's only affecting Latinas, even though I feel like some groups, just because of culture and beliefs and values, might be more affected than others. But I think everyone, we need to do better in terms of decreasing the anxiety and increasing the power. It comes with, this idea of knowledge gives you power to act and prevent disease.
Well, I've really been impressed with the amount of federal grants you're both receiving to do the fantastic work you're doing in breast cancer research. Anything else you would like to add?
Yeah, that I think we're very excited about the Mobile Mammo Plus and the opportunities that it will bring to the community, to UC Davis Health, and to the researchers, to learn from the diverse communities that we serve, and that we, because of the way the health system works, we haven't been able to reach out to everyone. And I think this will allow us to do exactly that. Or we really hope so.
I could add one more thing. So one of our hopes is to not only provide breast cancer screening on the van, but we want to expand the program to provide HPV testing for cervical cancer screening, and FIT testing for colorectal cancer screening, and then screen women to see if they're eligible for lung cancer screening. Lung cancer screening rates are extremely low, and we expect that a lot of these populations, these marginalized communities, will be eligible for lung cancer screening because smoking rates might be higher. And so we hope to expand this to be a whole cancer prevention program involving multiple types of cancers.
Thanks for joining us. We appreciate all your insight and just sharing with us too. Well, thanks for tuning in and listening today. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.